Good evening, everybody, and welcome to today's episode of Marvelous Medicine, which is around aerodigestive disorders in children. We are extremely privileged to have Dr. Ishwaran Venkatraman, Director, Children's Airway and Swallowing Center, Manipal Hospital, Bangalore, and also mentor for Pediatric Otolaryngology Fellowship Program and Adjunct Professor of Manipal Academy of Higher Education. Dr. Raman did his MBBS and MS ENT from Armed Forces Medical College, Pune. He's a member governing committee of the European Society of Pediatric Otolaryngology and the Asia Pacific Society of Pediatric Otolaryngology, Chairman Pediatric Otolaryngology Subcommittee, Indian Academy of Otolaryngology and Head and Neck Surgery. He has given several lectures and orations in India and abroad, including the Dr. Khan Memorial Oration of the Pakistan ENT Association and the Raj Bhandari Memorial Oration of the Nepal ENT Association. He's received several awards, including the Distinguished Teacher Award by the National Board of Examinations, Lifetime Achievement Award of Laryngology and Voice Association of India, and was awarded the Fellowship of the Indian Academy of Otolaryngology and Head and Neck Surgery. In 2023, Dr. Raman received the Gray Humanitarian Award, an award given by the Society of Ear, Nose, Throat Advances in Children every year to a member of the otolaryngology community who exemplifies the humanitarian philosophy of Stephen Gray, who was an icon of pediatric otolaryngology. We are indeed privileged to have him, and thank you, Colonel Hari Krishnan, for introducing us. Joining us will be Dr. S. Tirunavakarasu, Senior Consultant, Pediatric ENT and Airway Surgery in several leading children's hospitals and the lead for Center of Excellence in Pediatric Airway Surgery at Child Stress Hospital, Chennai. Dr. Thiru trained in India and Switzerland, and he has extensive experience in managing complex airway and aerodigestive disorders in children. He has several publications and book chapters to his credit. He's a reviewer of specialty journals and was the president of Laryngology and Voice Association of India. He has been an invited faculty at many national and international forums and has actively contributed to global discussions on multidisciplinary management of aerodigestive disorders. I should thank Dr. Mohan Kameshwaran for introducing me to Dr. Tirunavakarasu. Last but not the least, we have Dr. Ravi Shankar, who's additional professor, Neuro-Otology, Department of Neurosurgery, Sanjay Gandhi Postgraduate Institute of Medical Sciences. Dr. Ravi Shankar did his MBBS from Stanley Medical College, Chennai, and MS ENT from PGI Chandigarh. He's undergone training in neurotology in US, skull-based surgery in Italy and Switzerland. He has been an invited faculty in several national and international conferences and workshops. He has 50 plus peer-reviewed articles in international and national journals and 30 plus book chapters in neurosurgery and skull-based surgery textbooks. He's also on the editorial board of several journals. He received the Eugene N. Myers MD Global Education Grant from the American Academy of Otolaryngology and Head and Neck Surgery in 2024. His focus areas include skull-based pathology, fungal infections, transtemporal approaches, schwannomas, juvenile nasopharyngeal angiofibroma. Welcome, Dr. Ravi Shankar. Over to you, Dr. Raman.
Good evening. Thank you very much for inviting me. I owe thanks to both Vidya and Colonel Hari, who's been a childhood friend. And of course, my partner in crime is Dr. Tirunavakarasu. I'm so privileged that he's around. Young people like Thiru are the ones who are going to lead the specialty into the future. Also, I am privileged to have Dr. Ravi Shankar, a neurotologist. Just now I said they are the most cerebral of all the ENT surgeons. The rest of us are plumbers or we are carpenters, and they are the ones who are closest to the brain. So I'm privileged to have this kind of an august group here, and of course the audience who's logged in. So what I'm going to do today is basically talk about what we have done, and we want to share this experience with others, because what I'll do is I'll just, as an introductory slide, I'm going to play a video which is about 7 minutes, which kind of encapsulates everything of what we were doing, and then we'll tell you stone by stone, brick by brick, as to how we built up this center.
some people are both with purpose and some with a need. And some needs are very special ones, which can't be met by one and all. Many needy and unfortunate children don't even see the ray of light when they succumb to the airway problems, and sometimes even before diagnosing the disease. What we are witnessing ahead is an initiative that touches every heart of mankind.
When you have a child who cannot breathe and need a tube in the neck to help breathe, it can be a disaster for the family. It can be a huge change in life for everyone taking care of that child.
So in Manipal Hospital, we set up the Children's Airway and Swallowing Center, a multidisciplinary group which caters to the problems of these children. And we decided that we will all work free of cost and also collect money to help these children to fund their hospital stay.
The treatment of these patients is long. It takes a lot of effort and motivation on the part of the health caregivers and the doctors, and of course the cost of the infrastructure is pretty high.
In the last 23 years, over 2,000 patients have been evaluated and treated by this program.
ಈ ಪ್ರಾಬ್ಲಮ್ ನಮ್ಗೆ ಹೇಗೆ ಸ್ಟಾರ್ಟ್ ಆಯಿತು ಅಂದರೆ ಒಂದು ಸ್ಮಾಲ್ ಸಿಸ್ಟ್ ಇತ್ತು. ಸೊ ತಿರ್ಗಾ ಗೂಗಲೆಲ್ಲ ಸರ್ಚ್ ಮಾಡಿದಾಗ ನಮ್ಗೆ ಗೊತ್ತಾಯಿತು ಇಲ್ಲಿ EV ರಾಮ್ ಸರ್ ಇದ್ದಾರೆ, ಇಲ್ಲಿ ಬಂದು ಒಂದ್ಸಲಿ ಅಪ್ರೋಚ್ ಮಾಡೋಣ ಅಂತ. ಸೊ ಅಲ್ಲಿ ಅಪಾಯಿಂಟ್ಮೆಂಟ್ ಸಿಕ್ಕಿ ಅವ್ರ ಹತ್ರ ಟ್ರೀಟ್ಮೆಂಟ್ ತೊಗೊಂಡ್ಮೇಲೆ ಸೊ ವಿ ಗಾಟ್ ಎ ರಿಸಲ್ಟ್ ಲೈಕ್ ವಿ ನೆವರ್ ಥಾಟ್ ಇಟ್ ಈಸ್ ಸೋ ಈಸಿ ಇಲ್ಲಿ ಬಂದಮೇಲೆ. ಸೊ ಇಲ್ಲಿವರೆಗೂ ನಾವು 6 months ಆಗಿದೆ. ನನ್ನ ಮಗಳು ಟ್ರೆಕಾಸ್ಟಮಿ ಟ್ಯೂಬ್ ತೆಗೆದಿದ್ದಾಳೆ. ಶಿ ಈಸ್ ಟಾಕಿಂಗ್ ಆ್ಯಂಡ್ ಶಿ ಈಸ್ ರೆಡಿ ಟು ಗೋ ಸ್ಕೂಲ್ ದಿಸ್ ಕಮಿಂಗ್ ಇಯರ್. And we are very happy today. We are here to last surgery to closure that.
In fact, some of these children have accomplished such feats which they never thought they could. One of them, operated on day 7 of his life, is giving performances in classical Hindustani music. The other one won a medal, gold medal, in the Special Olympics in Bangkok recently.
Every breath a child takes is a promise of life, of laughter, of limitless potential. But for thousands of children across India, that promise is challenged from their very first breath by complex airway and swallowing disorders that threaten not just health, but the chance to thrive. 25 years ago, a bold vision took shape. The Children's Airway and Swallowing Center, or CASC, was born. What began as a small interdisciplinary initiative has grown into a nationally and globally recognized center of excellence, saving lives, restoring hope, and redefining what's possible. To date, CASC has transformed the lives of over 2,750 children. Children who now breathe, speak, and swallow with freedom. We've trained over 200 Indian doctors in this specialized field, nurturing the next generation of pediatric otolaryngologists, anesthesiologists, pulmonologists, and speech therapists. Our team has pioneered first-of-its-kind surgeries in India, contributed over 25 peer-reviewed publications, and helped shape new clinical standards in pediatric airway care. In partnership with MAHE, we proudly run 2 fellowship programs and are now poised to launch our first PhD program in pediatric otolaryngology. CASC has been honored with prestigious global awards, including the Stephen Gray Humanitarian Award and the Hanley Award for Outstanding Clinical Impact. But awards are not our greatest achievement. It's the quiet moments. A child's first clear breath, a parent's tear of relief, a voice that was once silent, now heard. This September, as we celebrate 25 years, our Silver Jubilee, we invite you to join us at the 8th Biennial CASC Conference in collaboration with the Aerodigestive Society of the USA, with global experts from 6 countries, live surgical workshops, and groundbreaking sessions. It will be a celebration of everything we've built together. CASC is not just a center. It is a movement, a humanitarian effort, a promise fulfilled. Breath by precious breath. Children's Airway and Swallowing Center, 25 years of healing, and just getting started.
So thank you very much for watching this film. It kind of tells us what we have done in the last 25 years. But what is the need for such a center? As you know, India is the most populous nation of 1.4 billion people. And out of 259 births per minute globally, India's share is 51. That means one birth every second. 41% of the population is of children and adolescents. That's around 400 million. And the WHO guideline recommends 1 per 1,000 doctors and 0.62 doctors per 1,000 population, and a deficit of 60,000 doctors and 2 million nurses. Now, 27% of neonatal deaths, 40% of low birth weight babies, and 25% of preterm births occur in India. So there's a huge population there which needs special expertise. And the current availability of doctors marginally exceeds the WHO recommendation of 1 per 1,000. And the Newborn Action Plan was initiated by the National Health Mission to reduce neonatal mortality rate to single digits by 2030. There's been an exponential rise of neonatal ICUs and PICUs, both in government and private sector. Advancements in ventilation techniques, availability of skilled manpower, and organized neonatal transport in the last 10 years has occurred. And the infant mortality rate in India has seen a dip of 42% from 2006 to 2017. So the significant increase in airway and swallowing problems of NICU, PICU graduates is due to improved survival rates of neonatal, infant, and pediatric cases. The multiple aerodigestive pathologies require different types of skill sets, ranging from counseling and therapy to skilled surgery. Inability to provide the appropriate care results in winning the battles but losing the war. Are we getting these children back to home, back to school, back to playground? And if they're still left with some kind of a disability after expensive intensive care and multiple interventions to make them better, that means we are not achieving our goal. Now, what are the hurdles? The hurdles for setting up a charitable surgical unit in a corporate hospital. You can't have a charitable center in a corporate hospital. That's an oxymoron. And why we need to do this is because the healthcare expenditure, up to 65%, is out of pocket. Many of these children have comorbidities, have undergone surgeries already, have raked up huge ICU bills for months due to their poor health. Lack of affordability in India drives 57 million into poverty each year. Apart from that, there is a low morale, frustration, and decreased trust of the medical profession by this time. And these are the children of a lesser God. And after so much is done, nobody has any sympathy for them, saying that, look, we've done all we could, and the child may have to tube feed, and the child may have to breathe through a hole through a tracheostomy the rest of their lives. So we analyzed as to why we can't provide good holistic care for these kids. One is, many of the people in the audience who are doctors will understand, sometimes we have very poor interdisciplinary communication between ourselves of different disciplines who are called to take care of these children. We don't sit down and talk to each other and see what is the most appropriate way of taking care of this child. Then there's a lack of skill in terms of taking care of these newborns and children who require very specialized care. Apart from that is the financial impediment of providing free subsidized care in a corporate hospital. So we had a very serendipitous beginning. Manipal Hospital is part of a nationwide chain of not 37, now I think 51 corporate hospitals. Enhanced high-volume pediatric cardiac surgery program was launched in 1999. This led to the emergence of a number of NICU, PICU graduates with airway and swallowing disorders, And in our anxiety to vacate beds for new children who were coming for the surgery, these were the nowhere children. They were not fit enough to go home, but they need not have stayed in the hospital. So this is care continuing beyond the hospital to home, as you will see in the following slides. There's always a spark you wait for. In October 1999, His Holiness the Dalai Lama had come to inaugurate the Children's Airway and Swallowing Wing. And that was a time when the pediatric intensivist from the cardiac unit came and told me that, look, these children are left with problems. Can't send them home, but the surgeons need more and more free beds. Now, how do I, get these children fit enough to go out? Can you help us? So we as oral surgeons were called upon to diagnose and manage these patients. To be very honest with you, at that time, our knowledge of aerodigestive disorders was very, very low. And the problem of the aerodigestive problems are, you see, it's a whole range. It's not a quick fix solution like you have cardiac valvular disease, or you have cataracts, or you have any clinical problem, which is repetitive surgery, reaching out, doing multiple assembly line procedures. This is not to belittle the great work done by cardiac surgeons and eye surgeons, but here the complexity is because of the varied disorders. There could be choanal atresia, as you see here. The back end of the nose is blocked, nasopharyngeal mass. There's a sublingual mucocele. There's a child with a large tongue preventing it from breathing. And here you have a simple valvular cyst. And one of the children you saw earlier in the video presentation was a child who came for a simple valvular cyst and landed up with multiple problems because inappropriate surgery, inappropriate use of instrumentations. And then this is the commonest reason why children have stridor, and that's due to the collapse of the larynx. And then children with other anomalies like bifid epiglottis, which are all syndromic problems. Then you have laryngeal hamartoma. So the multiple problems, each one needs a different kind of surgery. Here is the most extreme one. There's a non-canalization of the larynx. This child has absolutely no space between the vocal cords. And the good thing here is in the recent past, we've been able to diagnose some of these conditions antenatally, and you know that when the child is being born, this child has got this, what is called as chaos, chronic high airway obstruction syndrome, and it can be diagnosed by a fetal medical specialist, and we can take care of this child soon after birth or during the birth, during an elective cesarean, where the child is still connected with an umbilical cord to the mother. Mother's is like a heart-lung machine. It gives enough, about 52 minutes for us to restore the airway of the child. That is the advancement which has taken place. These are rare, and unless you keep seeing these cases, our expertise also doesn't build up. Hence the need for a specialized center where children are referred so that we get to see more cases. This is a simple laryngeal web. This is vocal cord palsies. This is a cleft between the larynx and the esophagus, and then leading to aspiration. Then here's a child with hemangioma. I'll show you a picture of this child. Here, the good news is that we moved away from surgery and we give medical treatment and the child becomes all right. This subglottic stenosis, this is due to iatrogenic emergency intubation for a child where it resulted in injury and scarring. And this is a floppy windpipe, that's a trachea. And here you have the trijunction here with complete tracheal rings. And this is another pathology. So we said that if you want to start anything, you can't ask people to help you unless you yourself set an example. And as doctors, we are no exception. I know we need to make our own living. We have to support ourselves. But then we have to devote a part of our life to doing work without any benefit. So we created an interdisciplinary volunteer group of doctors to offer services free of charge. And my selling point usually would be that many of us, or a large number of us, have studied in government medical colleges where somebody else, some taxpayers paid our medical fees, and this is give back time. Fortunately for me, the group around of multiple specialties all succumbed to this kind of coercion, or it appealed to them, they got inspired, and all of us worked free. Now we have the moral authority to request for help from others, and so that we could, kind of give back to society with the help of the community. And we found that when we started working free, that was not enough. The medical bills are a reality. That's the elephant in the room. You need to pay for the hospital bill. Somebody has to pay. You have 3 nurses per bed in the ICU. Who's going to pay their salary? They need to make a living. So we took the next step. These were our solutions. One is, of course, like I said before in the last slide, created a group of volunteers, built up a team of pediatricians, neonatologists, anesthetists, gastroenterologists, pulmonologists, pediatric immunologist is in our group now, and he's such an asset. We never thought immunology is going to be so important in this group. And of course, we have our swallow therapists, SLPs, and they are so important. Yeah, the people behind, and as doctors, we don't really bring them out into the open to help us out. So it truly, it's a one-stop shop for all things related to aerodigestive disorders. Otherwise, we found patients going from specialty to specialty, doctor to doctor, not being referred to the right place. So it's a single place where we sit together, diagnose the problem, and then the leading specialty gets involved in the program. Then the other thing was to create a training program for the next generation. If we have one center here, we probably have we need 80 to 100 integrated centers in our country. There are wonderful institutions in India, including the All India Institutes and various other central institutes and legacy institutes like CMC, etc., etc. But then again, I had the freedom of creating this center without the bureaucracy of a conventional medical college where you have to go to the administrator and keep asking them. The only thing we had to tell our corporate hospital, look, we're doing something which is going to be free, and please let us do it, and we're collecting money from the community. Next was a cost-effective and marketing and branding exercise. This was a real problem because a private hospital can never say that they're going to do, going to have a charitable center. So that had to be done with a little bit of, a sensitivity to the people running the hospital, because all these hospitals are now, the funding comes from investment bankers. So this is one of the smaller interdisciplinary group, but then here you have, we have the neonatologist, we have the pediatric gastroenterologist, these are the parents, and we didn't capture the other 3 people who were there. One was the swallow specialist, the pulmonologist was there. This was a child having a very severe laryngotracheal cleft, and the father was an auto rickshaw driver who had to sell his auto during the COVID times and didn't have enough money. And this was a child who was born after almost 15 years. First child died with similar problems after 1 year. So sitting together, explaining to them goes a long way. And fortunately, our team is absolutely tuned to these interdisciplinary groups. And this was just to illustrate a few things to you, this is our earliest case of what is called as an exit procedure. Exit procedure is extrauterine intrapartum therapy, where the airway is restored when the child is half delivered by an elective cesarean section, where the umbilical cord is still connected to the mother, and the child gets the oxygen through the circulation, placental circulation, and we have about 52 to 53 minutes. This is a cystic hygroma case, and you can either intubate the child, or you can do a tracheostomy, or you can just put a rigid bronchoscope there to oxygenate the child and subsequently do the definitive procedure. So you can imagine the number of people involved in this. You have 2 sets of anesthetists, one for the mother, one for the baby. Then you have the neonatologist, you have the pulmonologist, you have the ENT surgeons, all of us like hawkers standing inside the theater with our own telas or trolleys. We have to go center stage and try to help the child. So these are this is the extreme extent to which pediatric airway management, which is diagnosed prenatally, and then soon at birth time, this is being taken care of. So Children's Airway and Swallowing Center is a collaboration between the hospital management, which should allow us to do what we are doing. And I'm happy to tell you, in the last 4 to 5 years, when they understood exactly what I was doing, the hospital has come about and giving me I pay only for x-rays, medical equipment, drugs, and lab investigations. And all this we could plead, we could cajole, we could discuss with the management just because of one reason: we were standing on a pedestal because we were doing free work. We said we have no benefit from this except getting experience. So the hospital management, the doctors, now comes the community. Over a period of time, we do have patients who are richer than us, and you will be surprised as to the number of people who are willing to help. There's so much of goodness in our community. People just want the money to be used for the right things. And we built that up. And the other thing, like I said, was a single sitting evaluation so that these patients don't get fed up. And many of these children die because they're not aware of centers offering this help. They don't know where to go. And then, of course, they don't have the money and they don't know whether the child can get better or not. And we saw many cases where there was marital problems in the sense a mother left the child or father left the child and things like that because they just could not take the stress of managing a child 24 hours, tube fed and breathing through a tracheostomy. So that was the reason. And secondly, of course, I already pointed out to you, this is a multidisciplinary treatment team. It's a one-stop shop. Fundraising we did, and then we don't want to stop there. We want to train other doctors from what little we know. We want to share our knowledge and whatever problems we had in setting this up. The fund crunch, I told you, the professional fee waiver, it had a very small impact on the final bill because of the cost of modern medical care. Complex airway problems require multiple interventions. When I used to go and talk to people in the Rotary, they said, how many patients do you get in a month or a year? I said, I don't know. How many children will benefit from this? I don't know. How many surgeries would they require? I don't know. And organizations which are well organized, like the Rotary, which do phenomenal work, want everything in documented as to how their money is going to be used. So lack of all this prevented us from going to these people. That's why we had to go to the community at large. Then there's a lack of insurance coverage for congenital diseases, unfortunately. And charitable organizations, just I mentioned, Rotary, they want to give money to multiple for example, cardiac work where it's an assembly line procedure. You know exactly how many children are going to arrive at your center and how many of them are going to improve with one surgery or two surgeries. Anyway, so the good news was two things happened simultaneously, and I don't take credit for it. The government of India introduced a corporate social responsibility thing where 2% of net profits of the companies of the previous 3 years are to be spent on some kind of a community work. And that helped us. And also Bangalore was a town when I just started practice, was just growing, and many of our patients were like you and me, but then gradually over a period of time, they became CEOs. Somebody became, started a company and that grew, et cetera, et cetera. So we had a clientele which was willing to give us the money after some years. And here you can say a single organization has given this much money to us just because they trusted us. And another thing that what I did was I put this money in the Manipal Foundation. Most of the NGOs, when you give money, 30% or 25% goes to administrative expenditure. So when the donors heard that we don't even have a cup of tea, coffee, don't fly in specialists from anywhere else, we don't use this money for anything else but taking care of the children. And so our money stretches much more, along with the subsidy given by the hospital. Now, the upskilling is also a problem. Thiru is here. He'll also know how difficult it is to, train younger doctors. It's like a pilot and a co-pilot, the anesthetist and the surgeon, and working in a small area to let your assistant train and you also trying to, supervise it and take responsibility is very difficult. So some of these conditions are self-resolving. Some of these conditions are medically treatable. Some require minimal interventional surgery, some simple open surgery, some complex open surgeries, which has to be in stages. So we have to get the right fit, and diagnosing and having a treatment strategy is one of the most important things. So when I was young, I wanted to go abroad and like everybody else do training abroad, but I never got the opportunity. So I said, if I'm going to organize a training program, that's going to serve a few people. So why not get the international faculty to India? So we organized a biennial training program, and the best airway surgeons from the world come to our center. They operate, give talks, etc., etc. And the thing is that because of this, a large number of young Indian doctors not having the resources to go and train abroad are trained at home here. And it's an incremental path. The standard has gradually increased every 2 years. There's a biennial meeting that we have. And now we have a phenomenal national faculty. And you can see my friend sitting here. He's doing a great job. And like that, we have people in various parts of India, Lucknow, Gurgaon, Guwahati, Bombay, and people from all over, from Vijayawada. And this is our own fellow who's right now in the University of Iowa and already being appreciated for all her skills. So, and that is Dr. Mary Quillian from CMC Vellore, Dr. Mathur from Lady Hardin. So we got together, the national faculty, and all the international faculty traveled in their own expense. I don't give them 1 rupee. I just lodged them in a hotel for those 3 days. So the training stack was also important. I won't go into the details. I may not have too much time left in case we have some discussion, but then it was stacked up, the pre-test, didactic lectures, live evaluations, unedited surgical videos, live surgeries, hands-on 3D model dissection, good dissections, scopies on mannequins, case scenarios, post-test, and feedback. So that's the kind of cases that we've been given, and our module has had a 92% satisfaction. This is from the simplest to the most complex of the cases which were demonstrated. Here you can see the 3D printed larynx being used to practice some routine surgeries, and almost 89% said that they had more than expected responses for the live demonstration and the workstations. So the outcome of the international collaboration of the past 20 years is 100 complex airway surgeries, 87 cases successfully decannulated, 4% mortality due to non-airway related problems, 237 ORLs treated, trained with 137 attendees over the past 4, now it's actually 6, clinical update workshops. And we hold these conferences once in 2 years. Nothing happens so fast in medicine to have a yearly workshop. And also the fatigue factor goes away. That's why we made it. And these are the children who've come from multiple countries to our center: Saudi Arabia, Ethiopia, Maldives, and of course, Pakistan, Bangladesh, Maldives, Mauritius, etc., etc. And the good, gratifying thing is that fellows of the doctors working in other airway centers are coming to us for training, for short-term training, because the number of cases that we see in a short period, so very, very gratifying from that point of view. Now, this is a child whom I had mentioned to you. This is a child operated on day 7 for the voice of this child. And the same child, when he grew up, he started, sorry. So he trained in Hindustani classical music and started singing. Airway and voice, we managed to do both in this case. These are the cases which give us more energy, and it's the same boy running the Bombay Marathon here. So our follow-ups are long. The families are like... And here is the boy who won the... he was again, one of those messed up cases using lasers for a non-indicated thing. This boy finally won the Special Olympics badminton medal. And this is a child who was operated, I think, for 8 or 9 times and finally decannulated, and they came from a village in Haryana. And sometimes these are the rewards we get for our work. It's not peanuts. It's much more than that. It's so gratifying when they come with these things. And one of our patients after the surgical program was still hanging around the hospital. And he said, I thought you were going to buy my tickets home. So that is a kind of confidence we give to our patients. And this is a child again, just to illustrate. And the child completely comfortable now and had a subglottic hemangioma, which was treated with medicine, propranolol. So this is very gratifying again. And you have to train the caregivers. Here, there's a child who lives in one of the rural areas, no electricity, and so there's a manually operated
ಪೈಪ್ ಹಾಕೊಂಡೇ ಇಲ್ಲಲ್ಲ ನಾನು
and the
ಹಂಗೆ
child
ಹಾಕೊಂತೇನೆ
himself does the suction. We
ಹಂಗೆ
told them to wash hands before that, to follow as much hygiene procedure as possible. And they were daily wages workers. And the grandmother was the one who was taking care because
ಇದೆಂತದಿದು ಮಷೀನ್
there she's using the pedal, and there the boy is doing the suction. So that's the kind of real world scenario. We buy we rent the suction machines and give it to the children till the child is decannulated. So this again, you see the kind of adulation they have for you. They put it next to the calendar. They put a big picture. It's such an honor to be revered and remembered. And he's, of course, a soldier who is transferred from place to place, and this child didn't get the appropriate treatment for various reasons. We took care of them. And this child, you can see this, apna time aayega, this kid says. And listen to the voice of this child. There's absolutely no voice. She's trying to tell ABCD. So we operated on this child without a tracheostomy, without putting any stent or anything. And these are one of our This is about 2 weeks after surgery, and these are the reasons that we feel so fulfilled with what we are doing. So the mission statement of CAC, to conclude, is establish multidisciplinary care for children with airway and swallowing disorders, better interspecialty communication, having a committed member in each of the specialties, hold conferences to upgrade the skills of the doctors interested in this area, build a private-public partnership to help patients from government children's hospitals. The health secretary of the Karnataka government had come about 2 years back, and he says, "Doctor, what can we do for this?" I said, "Don't do anything. Take care of dengue, take care of malaria, take care of all those things, but encourage people like us who want to help out children in the government hospital. Not that government hospitals are bad, but then we can break bureaucracies and build centers. Kindly support us and help us." So the whole idea is to create a model to subsidize the cost of care by voluntary honorary work and contributions from the community. And we got international recognition when we were recognized, and I'm using the title that they gave me to write an op-ed in the International Journal of Pediatric Otolaryngology for this lecture also. And this is, of course, the Gray Humanitarian Award, and I can proudly say that the first time a non-American got it. And it's all the team of neonatologists, anesthetists, intensivists, speech and language pathologists, and of course, the management of Manipal Hospital for letting us do what we are doing. So mainly to our patients also. And now I need to thank all of you for your patient hearing. I'll be glad to answer any questions or any comments from our experts sitting there.
So if you don't mind, you can stop sharing your screen.
Oh, yeah, sure. Stop sharing the screen. Okay. Okay, here we go.
Over to you, Dr. Tirunavagar.
Thank you so much, ma'am. Thank you, sir, Raman sir, for giving this wonderful lecture. And it is not exactly a lecture. It is something like words from trailblazer in the field of pediatric airway. Because the pediatric airway is a very niche field. We have been, listening to your talks in airway meetings and other, meetings where the professionals who are dealing with these kids are present. But here in this forum, this is like, the general physicians and the other specialty people, and even the general public are going to see this lecture, and it's going to be a eye-opener for many of them, And that way, we will have to thank Dr. Vidya for giving this opportunity to present our work in the marvelous medicine, which is very popular. And you are the right person to give this talk and take this message to the general public, because the most of the kids who are having these problems or either not treated or they're not aware these things can be done. Because when I was a student, it is like, if a kid is on trek, the child will be with trek forever. So you can't do anything more than that. So now, the idea of doing anything in airway is to bring the tracheostomy tube out if any child is on tracheostomy. That's why, we need to, give this awareness to the general public and the healthcare professionals that any child is having tracheostomy tube has to be, evaluated, and we try to remove the tube out. So my question to Dr. Raman is to, how to, propagate this idea of doing airway surgeries and the treatment for kids with this kind of problems, because many children now are wonderfully treated in ICU and PICU, and they're, bringing out of the children from deathbed. But they are coming out with morbidities because of the lot of children in every small cities. The PSUs and NSUs are being run nowadays, and we need to give this kind of information to the every healthcare worker and the general public. What way, apart from this forum, like what we do here, we can how can we propagate the knowledge and awareness about this field to the larger audience?
Thiru, to answer your question, it's like a domino effect. Now, wonderful work going on at your center in Bombay, in Guwahati, in Visakhapatnam, and I'm missing, of course, CMC Vellore and so many other places. The only thing is that I said in the government hospitals have a lot of advantages. Private hospitals also, apart from the disadvantages, have their advantages. The problem with the universities and government hospitals are the bureaucracies. And thirdly, we are never trained as doctors. I'm speaking on behalf of all the doctors in the audience and in the forum also, that we have not taught how to work together for some reason. And each specialty looks at the same problem in different ways. You go to a spine problem to a neurosurgeon, he looks at it slightly differently than the spine surgeon versus the orthopedic surgeon. Here, it's multiple different specialties, and swallowing an air, as you know, it involves so many other intricate things. So we need input from all of them. First thing is to work together. That is important. Second thing is, of course, to create awareness. You've already done a great job. I mean, we are in touch with pediatricians, we are in touch with neonatologists. It's a question of time, but we need to accelerate the whole thing. And if we can manage to do everything in one place, in one sitting, because parents also, every time a parent comes and I feel I'm operating the child free, I think I'm doing a great job. What I don't understand or realize is that they've left their job, they've spent money on the transport, they're sitting in hospital. They're also investing in that particular thing. So to make it accessible, and I know that our government children's hospitals are very, very overcrowded. The doctors are good, professional, but they don't have time to do esoteric work like this. So I think each one of us can adopt them, or they can adopt us, whichever they want to call us. And as a center where we keep talking in the politics about private-public partnership, why can't we do that? So our whole idea is, look, it's worked in a small way in our place. It can be duplicated in multiple places. And you're right, there are obstacles, but I see a lot of sparks, young people like you, you're doing great work. And I think you should continue to do that. And Lee, of course, as you said, without crass advertising, we need to tell people that, let people know that we are there.
Dr. Avishankar, would you like to come in now?
Yes, sir. Sir, it's a fantastic talk, and it's really inspiring. And you highlighted the importance of teamwork and how we are managing the different spectrum of difficult airway pathologies. And in my experience, we are working in a different kind of setup. So we are primarily deal with skull-based pathologies, and we have the beautiful team of pediatric surgery as well as the maternal reproductive health. So what we encounter is primarily the congenital teratomas, hygromas, and the lesions extending neck to thorax. So in these scenarios, we primarily get the help from the pediatric surgeon, other than the team what you mentioned. So we frequently get the help of a pediatric surgery in my airway management. That is one thing I need to highlight. And one thing, sir, one suggestion from your expertise. So what we encountering is that common problem is the common indications for the pediatric tracheostomy, because in our centers we have running a multiple ICU, and very few are aware of the indication of pediatric tracheostomy, because the pediatric tracheostomy is the most usually I avoid as much as possible, but still sometimes it's not in my not in my hands, and they will go for the tracheostomy for the non-indicated cases. So the creating the awareness of absolute indications of pediatric tracheostomy among the medical fraternity is more important, I feel. So what about your opinion on this, sir?
Absolutely. We have joint meetings with neonatologists. We have joint meetings with pediatricians, pediatric intensivists. And so that is a way we have to share each other's experience. And it should not be that the ENT surgeon is some high fellow who's talking down to the others. We should share experience. They have expertise, we have expertise. And non-invasive ventilation techniques have improved so much that the number of pediatric tracheostomies have gone down. But are the intensivists and neonatologists adequately trained?
That's right.
These other things, but it's an ongoing process. I'm very, very positive. You see, I'm sure I can speak on behalf of Thiru also. We are ordinary doctors, ENT guys. We've been able to do something, means, everybody can do it. It's not that we can't do it, but we have to keep apart some time, some motivation, some passion, and encourage our juniors also to go ahead with it. I've been lucky. And I'm sure this is just, I remember a quote in BBC television series during the Christmas time, and there's a park in New York where there's a huge board saying that Elizabeth so-and-so donated money for this. So this guy, correspondent, asked, if you're doing charity, why the hell are you advertising this? So this lady says, if Elizabeth can do it, I can do it, is what my neighbor is going to say. So that's what we need to do. So we need to kind of, have a domino effect and things going on.
True, sir. True.
Dr. Raman, Dr. Vidyadharan is on the call. So, Dr. Vidyadharan, would you like to? He previously spoke on Marvelous Medicine on swallowing disorders, but obviously mainly focusing on adults. So, over to you, Vidyadharan.
Thank you, ma'am. Sir, ma'am, thank you for giving us this opportunity to hear sir's talk. I have been.
Hi.
Hello, sir. How are you, sir?
Doing well. Yeah.
So, sir, you are just I was telling madam, you're an inspiration and you're creating a legacy. I know it's very difficult when you have a niche specialty and creating the path. And Thiru sir has been doing this, his hard work in Tamil Nadu for so many years, and I've been trying to collaborate for my adult patient with sir. Sir has been helping, and like you said, teamwork is very important, multidisciplinary. And even though we are ENT surgeons, we deal with different subspecialization, we still kind of, feed off each other, learn from each other. So that was a good thing, sir. And recently also when I operated with Thiru sir, there was one patient, an adult patient, I wanted to take out extra tissue. He was like, no, less tissue. So we make our own piece in the theater also, say, okay, we work on. So when you started out, I can imagine how much difficulties you would have faced to create the specialty and convince people also, when they come and say, look, I have to do 2 different type of stage surgery. Even the parents would not understand. Other ENT surgeons may also not understand. So kudos to you, sir. You've created a path, and I've been attending sir's course whenever I can. I'm sorry I missed last year's 25th. It was a big course last year, but hopefully I'll keep attending future, sir. So keep continuing your legacy, and hopefully we'll all follow. And Deepa is a good friend, and I see how she's bloomed with your guidance. So if many more people, you and Thiru sir need to train, and a lot of people in different corners of the different cities of India, we need those kind of people, sir.
Absolutely. I think this has to multiply and grow more and more. And thanks. Again, same problem with Thiru also said of how to create awareness without marketing, actually, and do all those things are always there. Training young people is very, very important.
And one suggestion is regarding insurance for congenital anomalies, sir. I don't know if they can do that. That will be good. Congenital anomalies, rehabilitation. These are the things. Sometimes I tell to myself, they got insurance for coagulator. They can do something for other things, anomalies and rehab, and these things will be helpful, sir. But I think you, as a society or a representative, could push that, sir, in the airway societies and stuff like that. Sir.
The problem basically is the multiple pathologies which are involved. So what should we authorize, what should not authorize? That's a problem with the insurance companies. But then insurance companies are there to make money. Corporate hospitals are there to make money. You can't fight with that. Somebody is investing, they have to give them their return. So we have to find some kind of a neutral ground, even though it may be slippery sand, stand there and then try to do as much as possible.
Even if it's a foundation, how do we get people to donate and create that awareness that you're setting the path, and Tirusa is doing the same here. I was talking to him the other day. So hopefully we find a solution.
It's my dream. I may or may not accomplish this. So I always feel that younger people starting elsewhere, because I've collected about 4.5 crores up till now. I've been lucky. But my point is, I want to ask my donors, suppose I'm not doing the surgery, Thiru is doing it in Chennai. Can I give my money to one deserving child? Is that acceptable to you? They should know what I'm using it for. Because in our hospital, what I've done is I put this money in a Manipal foundation. So the Manipal administration doesn't think I'm doing some side business. You see, the distrust is so much sometimes. So that's what I do. So whether I can send that money to whoever youngster who's doing it in some place, but the assurance we want from them is two. One is the doctor should work free. And the second one is that the institution also should give a substantial concession. Then we will be able to transfer the money to those people. This is what we are planning. Whether it works or not, I don't know, but I'm sure it will help a lot of young ENT specialists who want to get into this field so that they get enough numbers.
Because not all the families cannot travel to different places.
Yeah, absolutely. Thank you.
Thank you.
Thank you so much.
Raman, I'd like to continue where Dr. Avishankar left off. Among all the activities that you said, it seems that, fairly a sizable percentage are iatrogenic or, things not congenital.
Yes.
So are you, what has been your focus on prevention? Like if even 20 or 30% of these problems can be prevented. So what is the work that is happening in that area?
So we have a joint meeting with pediatric intensivists and neonatologists and regular pediatricians, emergency specialists on safe intubation practices. See, that's one of the reasons that they get. Other one is setting our own house in order, which Thiru will agree. We ENT surgeons, not all of us are trained properly. So we just go and nibble at something and come back. And many cases are half done or some additional damage is also done. You're very right. Iatrogenic problems, which is within our community, that should be contained first. Congenital, we have no control. So there are guidelines these days, and then the anesthetists are very, very, you can imagine our anesthesia team earlier with Dr. Jayashree and Dr. Gayatri now, phenomenal. The amount they're involved, and I'm sure Thiru also has an equally dedicated team. Without anesthetists, without intensive care specialists, that's another warning. Please don't do these surgeries if you don't have a backup. Not that you're incompetent, but because background is not there, you can't do it. So that is very important. So we constantly have meetings where we say safe intubation practices. And of course, the other thing, as I was telling you, is non-invasive ventilation, and all those things have really helped us. Advances in anesthesia has helped us. So that's a way forward. And what you're saying is right. I think iatrogenic things which can be controlled should be controlled 100%. Right now, we also expect the news and the additional problem that's coming up, I'm sure it comes in every metropolitan city now, is the large number of boutique hospitals which take care of mother and child, maternity, and they don't have the backup for some of these complicated cases. They should also be enticed or told to, look, you can't do everything there. If you have a problem, we'll take care of the child. And most of them, because they need to maintain their reputation, don't mind referring the child, provided we are reasonable and we don't talk down to them, but talk to them as equals.
A related question is from Dr. Suman Lata, anesthesiologist. She wants to know how she could take any of these training courses. Do you have courses for ENT anesthetist as well, airway specialization.
For ENT?
For anesthesiologists to train.
Anesthesiologist, yes. We always have a satellite session for anesthesiologists during our conference. We have a satellite session for anesthesiologists to learn endoscopies and also safe intubations. And there are a lot of new techniques these days for to intubate in a difficult to visualize larynx. All those things are taught, and the Stores company is a collaborator with us because they have a lot of instruments that is being done. And then we have a joint session with pediatric gastroenterologists and also with pediatric intensivists. Cross-specialty training is going on, and there are special satellite courses during pediatric airway surgery conferences should be held. And I'm sure all of us are always there to come and help out in any which way we can. I'm not speaking to myself. The good thing about the airway surgeons in India, we call them the Indian Air Force. We work together. We have no ego. We have no associations. So there's no president. There's no prime minister. We are all equal.
I assume you would be needing specialized nursing as well, isn't it?
Absolutely, absolutely. So we have this two things we have. In fact, one of our works has just been published in an international journal called Laryngoscope of a novel, this thing on code blue and code green time, where the ENT surgeon also should be involved regarding trachs, etc., etc. So we have what is called as a pediatric emergency team, the PET team, which is kept in constant awareness of what patients we are getting. So any child who comes in with an airway or a swallowing problem, the PET team assesses the child so that at 3 o'clock in the morning when they come to when we call them, they're not caught unawares. They know such a child has been admitted to the hospital. We may or may not require their services. And especially when we shift a child from NICU, PICU to the regular ward, suddenly becomes bad, and when to shift the child at 3 o'clock early morning. So we have the PET team, which are specially trained nurses. We also have an airway nurse team who are trained in tracheostomy care, etc., etc.
Thank you, sir. Colonel Harrison, you have your camera on. Would you like to say something, sir?
So glad. Yes, I would very much like to say something. Some of the doctors here said that Dr. Raman is an inspiration, and I can assure you he is, because when I was a school student, he, along with my sister, were the two people who really inspired me to take up medicine as a avocation. And so I think inspiration was inborn with him in his own pediatric days. So I'm not surprised at all. Having said that, I've heard him mention all this to me more than once during my visits to India. And every time I've been thinking that this needs to be brought to some sort of a forum where people can hear and know what sort of good work he's doing. But I never realized this is the extent of the work that you're doing, Dr. Raman, and I'm really beholden to you, honestly. And that is why I chose this forum to introduce you, because Dr. Vidya and Dr. Patta are doing human service by bringing in so many wonderful sessions to a large audience of doctors from all specialties, as somebody else also pointed out. I've got just one suggestion for you. Perhaps you could do an Elizabeth at home here. You know, you talked about Elizabeth in New York Central Park. Maybe what you could do is you could get hold of your major sponsors who have given you the money, that crores of money, celebrate them, but make sure that every other big shot in the industry is also invited to that party, so that they realize that if they can be Elizabeth, so can we. So maybe that will open up opportunities for Dr. Thiru and Dr. Ravi and all those others also to carry on their work without having to worry too much about it. But I must congratulate you on the teamwork that you've been building on. I think that is the core basic requirement for all of us to get over our egos and work together for the benefit of society. Thank you so much, Dr. Vidya.
Agree with you. And I'm just preparing the second tier and third tier because I'm going to retire soon. So that is another thing all of us have to think of to make the institution live after you.
Basmati, you have your camera on. Would you like to say something?
Nothing really specific, but I've heard all this. Hello, Raman. I've heard it straight from his mouth because his wife, Dr. Raman's wife, and I were classmates in school, and we have some more classmates who've joined because all of us have had the pleasure of hearing him tell us the story, and we all wanted to hear it again. And I think I echo what other doctors have said about trying to fundraise further for this. And running an NGO myself, I know what challenges you were talking about. I can completely relate to that. And if ever I get some brainwave, I'll definitely pass that on. Thank you so much. Thank you, Dr. Vidya. Interestingly, just when I saw the message from her, 2 minutes before that, I was thinking out of the box that I should tell her about you and Dr. I think, who was it, who already had recommended. And it was wonderful seeing that you were on to this platform.
I just need to say one more thing. All of us who want to do this kind of work, we think getting funds is the most difficult thing. I can tell you it's not that difficult. Once you set up relationships, and you will be surprised, and my younger doctors working with me, they will tell you, our donors call up and say, why haven't you asked money this year? And one phone call, I'm sorry, I'm showing off now. One phone call from me to some of my donors nets me a minimum of 5 lakhs. So that is the amount of good will that is there out there. We need to trap it once they are convinced. That's the way it is. So that's not but we have to set an example. We should work free. I'm really insisting. We have other avenues of making money, ear surgeries or whatever. And this one, you leave it because it's your passion. And then that's the way to go ahead. Or Ravi wants to do certain types of exotic neurosurgeries. You should set apart time. Sorry to talk to you as though you're a young man. I'm sure you're young, Ravi, but then.
It's okay.
Dr. Tirunakar, would you like to add something after whatever discussion has gone on?
Yeah, I mean, see, the crux of the whole meeting is how to do, good community work with the teamwork. So that's what Dr. Raman is insisting on from the beginning. So, this is the one field where there is no president, no prime minister, as he said. Where every single person who is involved in this is so important, because whatever good surgery you are doing, if the staff nurse who is looking after the tracheostomy is not good enough, we will lose the child. So we have to have due respect for each and every person who is involved in this work, and we need to have a combined work together, like anesthesiologist, pulmonologist, intensivist, all these people. Because in our meetings, all the meetings, unlike in other meetings, we will have everyone there. Like, like in our meeting, anesthesiologist will be there, intensivist will be there, and pulmonologist will be there, gastroenterologist will be there, swallowpathologist will be there. So we all work together, and our meetings are like for everyone who is involved in the airway. Airway is being shared by many people. So that way, we have to, work together, and slowly that's also catching up. But last week, IAPA meeting, Indian Pediatric Anesthesiologist Association meeting in Bangalore, I went and I did a sheep dissection for the anterior airway access for cricothyrotomy and tracheostomy with difficult intubation. So this is being done in every IAPA meeting, and I'm attending for the 4th time. So they are like, they know where is the cricothyroid muscle is, where is the cricothyroid triangle, where is the, tracheal rings, where in emergency situation, how to manage. You can read all these things, but, in emergency situation, doing a cricothyrotomy is not that easy job, that too in children. So we need to, educate people. We need to have multiple meetings in different specialty conferences, and like the forum like this, where the different specialty people are attending. So we need to, focus more on that, and that is the way we need to follow from the seniors like you and Dr. Raman and the others. We have to follow your footsteps and propagate this knowledge to other youngsters. Thank you so much for the platform. Thank you.
Kalyani, you had your camera on briefly. Did you want to say something? Kalyani is a medical oncologist from Texas.
Yeah, thank you. Hi, Vidya. So Ravi Shankar sent a message on our WhatsApp group and said, this is an amazing talk he heard. So I missed the beginning part. Actually, I joined late. So but I wanted to see Dr. Raman, and that's say thank you for whatever his. I read about his stories and the patients that he saved. There is a on his Manipal website and other platform, like he has these children that he saved. So that's and then my classmate Venkatesh Madhugiri, he was a neurosurgery resident at NIMHANS, and followed by that he was a faculty as well, and he said he is a Bangalore native. Now he's in the US, but he worked with Dr. Raman on some of the neurosurgical cases. Dr. Raman from ENT would and then would collaborate with the surgeons at NIMHANS. So that's I mean, Venkatesh, we have great respect for him, and then Venkatesh said that. So Dr. Raman, thank you for everything that you do, and I will listen to your episode later. Vidya sends me, or I will be able to find them on YouTube.
And the other thing I want to say is that we are the second integrated center to be established in the whole world. Cincinnati started the aerodigestive center, and we did it because of the need, because we needed beds in the cardiac ICU. So, necessity is the mother of invention kind of a thing.
Right.
We found that our knowledge was not adequate. We just assembled the crowds. And now interdisciplinary groups are the need of the hour to reduce costs, reduce hospitalization, and give improved outcomes in any multi-specialty areas and most diseases are multi-specialty, if you ask me. Also there.
Yes. Thank you, Dr. Raman.
Dr. Tirunakar, so you have a junior of yours from college, Dr. Venkatesh, who's logged in. He immediately recognized your picture. And Venkatesh, would you like to say something?
Hello. Yes, ma'am. Thank you. Dr. Tirunakar, I don't know whether you remember me. I'm 93 batch. I was pretty junior to you.
I do.
Nandakumar and a few other guys, we were there. So
I know.
I actually need your number, sir.
Sure.
So we have a group.
I will give it to you.
Sure. So kind of you. Nice seeing you, sir. Thank you.
Thank you.
And excellent talk by Dr. Raman, sir. So inspiring. I mean, such a complicated area, aerodigestive disorders. Pediatrics is something I'm really scared of, and the pediatric surgeons I'm really scared of. So,
as an anesthesiologist, I'll tell you, pediatric surgeons are the most loveliest guys, the best surgeons. Pediatric
surgeons. Yeah, that's true. So thank you.
So if anyone else has any questions or comments, please feel free to turn on your camera or raise your electronic hand or type your comments in the chat box. Till then, we'll go to Radhakrishna. Actually, there was something strange, Dr. Raman, today. Whenever we try to access any of the Manipal websites online, it came as forbidden. So finally, I had to find some circuitous route to find your, the airways and swallowing centers details. For some reason, it was anytime you clicked on a Manipal website, it was coming as forbidden. So maybe you should tell your management about. So over to you, Radhakrishnan.
Firstly, amazing work, and I'm very, very impressed. And more impressed by the way Dr. Raman spoke. The video is fantastic, very, very inspiring. Actually, I'm the one who makes the posters for Vidya. I'm the poster boy, and I've been doing it for the last 5 years. And when I saw the title, building a team where there's no stadium, then I was wondering, this is a charitable institution in some rural area in a thatched roof, something of that nature. I thought, when they say no building, I never thought it's got something corporate hospital. Then when I Googled EV Raman, everywhere it says the top ENT surgeon in Bangalore. Then nowhere, when I typed charitable aerodigestive center, it didn't show anything, I couldn't write. Usually I write the introduction. then I wondered where is this charitable aerodigestive center in India, which part, which village? Because I thought maybe in some missionary hospital or some rural hospital, unused or a primary health center. Only this afternoon I got news from Vidya that's in Manipal Hospital. I wondered how Manipal Hospital will have charitable work. They don't go together. I was really surprised looking into the story. And I've been in corporate hospital from the very beginning of my career, and where is charity in it's just simple. I think you've done something which nobody has done. I mean, it's a great achievement. Secondly, actually, the surgeon's bill is a very minuscule part of any bill. I do not know how, I mean, surgeons or anesthetists writing off the, and of course, anesthetists is even more minuscule. Writing off their charges will anyway reduce. Corporate bills are tremendous. And then the thing that intrigued me is that how can a corporate doctor go to public and ask for money? The public will laugh, said this chap is making money. He goes in Mercedes, and how can he ask for money? These are all things I can't just. And now you went on and on to say that it's not at all difficult to get money. I cannot actually. I deal with adult gastrointestinal tract surgeries, and I never tried, as a matter of fact. And I don't know who are the ones who donate. There's some talent which, in addition to how you treat complicated aerodigestive disorders, you should also teach people how to ask people money and get money. I think that is something which doctors are very, very poor at, especially the corporate ones. Now, the problem again is the surgeries you do are complex, and the patients are likely to stay longer than usual, and a longer stays, longer bill. Outcomes you are not very sure, and then many of them require occupational therapy, this therapy, that therapy. These are all huge, very prolonged treatment protocols. It is another big challenge. It's possible that we can do some sort of a service in babies or pediatric or neonatal and cardiac ENT. The same thing is not possible in adults. So I can't dream of doing something charitable in a corporate hospital. Altogether, wonderful jobs. First time I'm coming across someone who's done things very differently. I mean, you'll be a great inspiration to many people. Wonderful, sir. Very inspiring. Thank you.
Thank you.
Dr. Vidya, can I just add one word?
Please go ahead. I'm just looking at the chat box. Please go ahead.
In a lighter vein, I must say this. Dr. Raman and I have a very good common friend who also happens to be an ENT surgeon, but he has lived all his life in the UK. And he once told me that, you know what? I know your friend Raman. Poor chap, he missed the Nobel Prize by just 2 letters. If it only. But now I'm beginning to feel, after listening to you, Dr. Raman, that it should not make a great deal of difference. I think what you're doing, as Dr. Patta said, is something phenomenal. I sincerely hope somebody notices it. And if you win a Nobel Prize, I know all the money will go for charity. So,
I have one point to make, sir. Have your center been replicated anywhere else in India by your trainees, assistants, or anywhere else in the world, or even in Middle East or in Africa?
Yeah. So, you see, if I say it might be misconstrued that I'm taking credit for their good work. But having said that, at least about one center I can talk about is the one in Guwahati, where Biswajit Gogoi, one of our youngsters who came for training for the first time to our course, is now doing wonderful work. So I always love to shine in borrowed glory. So I say Biswajit is doing his wonderful work thanks to us. But having said that, I'm really proud of what he's doing. Similarly, we've started helping out people in Bhubaneswar. So I think we have to, kind of spread these news that it is possible and we have to do it. Commitment, team. I think I've just been plain lucky.
Yeah, Vidya.
So Ravi Shankar, my friend, and he's also part of the Marvelous Medicine family, always thinking up topics and speakers, and because he works in the US, it's like bang in the beginning of his work day, but still he manages to push meetings and join here. So let's hope his wish comes true. He said somebody give Dr. Raman a Padma Shri. So hopefully that's in the pipeline sometime soon. If there are no other questions or comments, we will close the meeting. Your closing comments, Dr. Ravi Shankar?
No, no, ma'am. Thank you. It was a wonderful sessions, and it was, of course, eye-opening for me. And thanks for the input, sir. And I'm also looking for the funds for the hearing rehabilitations, and started this process. And hopefully, I will try my best to get the funds for this my hearing rehabilitation programs. And thanks for the opportunity for this wonderful session, ma'am. Thank you.
Your closing comments, Dr. Tirunavagar.
No, thank you so much for both of you for bringing it together, and the whole of the younger generation like us are getting benefited ultimately. Thank you so much.
Marvelous Medicine is a small effort at interdisciplinary cooperation. So we always tell all the speakers that your audience is not your specialty. Please, tailor your talk. Like a gastroenterologist, what they are speaking should be understood by a nephrologist or anesthetist or whatever. So that is our small way. Your closing comments, Raman sir.
More power to you, Dr. Vidya. You're doing wonderful work. Disseminating knowledge and experience is as important as anything else. The news should reach the right kind of people. When I say right kind of people, the givers and the recipients. The givers, the doctors, the recipients, the patients. Unless these two get together, nothing can happen. And you're facilitating that. I'm an ex-Air Force doctor, so salute to you.
Thank you, sir. Ram, you've got your camera on. Did you want to say something? You're muted, Ram.
Yeah, Vidya, thank you for noticing that I was Dr. Raman. It was, I don't know, amazing to listen to the work that you've been doing. And it just happened that, I was returning from Delhi, and I was coming back from the airport, Bangalore to Manipal. Vani, my wife, informed me that this talk is on. So I listened to the talk all the way. Unfortunately, my signal was not too good to say anything. And I just reached home. That's my luck. And I want to say that it was an amazing talk. And I feel that pediatric anesthesia itself is difficult. And airway in any age is difficult. And dealing with a difficult pediatric airway is doubly difficult. And I think your team has done a great job. Thank you so much. Thank you so much. A very enlightening talk. Thank you.
So
Thank you.
incidentally, Ram Kumar is, as he mentioned, anesthesiologist, and he's part of the Mission Smile, where we do a lot of, free work. That is, as doctors, we do the free work, and the funding is done by the CSR. So we do a lot of. So I had shared the link saying that so many cleft lip palate children also land up with aerodigestive disorders, pharyngoplasty, so many issues. So I assume that some of the people who work on cleft lip palate also logged in today. So thank you once again, and thank you, Colonel Hari Krishnan, for getting us together. It's doing this marvelous medicine. I realize how much we don't even know about what is happening in our own backyard. So thank you for giving us an opportunity to meet people like Dr. Raman, who are doing human service. We hope to have you again soon in the coming months. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Can I slip in a
Thank you.
Any child requiring any kind of airway surgery who wants to get it done free, send them to us. Who cannot afford? Who cannot afford?
Oh, right.
Who cannot afford? Continue to do your good work at the other place, but if child cannot afford, we are there.
Thank you. Thank you so much.